Morning, everybody. Dr. Gillard here once again. Let's do part 2 of endocrinology. It is the spring of 2020. It's week 7, and it is Tuesday. We were talking about Cushing's. There's an interesting article I came across actually last night. And we have 2 identical twins, only they don't look so identical, do they? This is easy, right? Which one of these has Cushing syndrome? Definitely this one, right? How do you know? Moon face, right? They got the moon face. Probably makeup on to hide the plethora, but there's probably some redness underneath here as well. Interestingly too, so let me just jump over. So not too long after that photo, she woke up one morning like that. What's that? That's ptosis, right? So what cranial nerve could cause that? That is close to the optic nerve in the optic chiasm. Oculomotor nerve, good. So we got to pushing into the oculomotor nerve. Full palsy, right? It's completely closed, so it's severely compressed. But she got an MRI of the brain, and lo and behold, there was a 8 millimeter tumor in the anterior pituitary. It was a corticotroph tumor made of corticotroph cells. What do corticotroph cells spit out? POMC, which is converted to ACTH, adrenal corticotropic hormone, and that does what? Stimulates the adrenal cortex to release cortisol. If you don't know that by now, and you're in my class, I am worried about you for next week. You should know that. That's just a little review. All right, so we're almost finished with Cushing's disease, Cushing's syndrome. Let's talk about some of the treatments, and then we'll go on to other things. So the adrenal causes of Cushing syndrome, so these would be ACTH-dependent or independent, if it's an adrenal cause. Well, it's ACTH-independent because it doesn't care about ACTH. ACTH is normal. That means it's a tumor, probably an adenoma right inside the adrenal gland that's spitting out cortisol all by itself. And if it spits out cortisol, high levels of cortisol, how's the ACTH levels going to be? Making you think on this one. Well, if there's high cortisol, remember the double negative feedback system, which I must have went over 4 times, so I won't do it again. But yeah, so ACTH is going to be shut down. How's the good adrenal gland going to be doing? It's going to be shut down, right? Yeah, because ACTH is shut off because of this monster secreting tons of cortisol. So if you have, and the most common cause is a unilateral, really rare to get a bilateral adrenal adenoma. It could, but unusual. So what's the treatment for it? If you have one adrenal gland that's messed up, it's got a tumor in it, you just take the entire adrenal gland out because you have another one on your other kidney. And so that's the fix. The trouble is, because of the double negative feedback inhibition, the good adrenal gland is turned off, so there's no ACTH around. So we have to wake up the HP axis and wake that up and get some ACTH flowing out of the anterior pituitary once again, and CRH flowing out of the hypothalamus, right? Paraventricular nucleus of the hypothalamus, to be exact. And that can take a long time. It can take months, at least months, but it could take a year or sometimes even more. So it's a long recovery on these things. Therefore, in the mean term, or you have to have some glucocorticoid replacement therapy going on to kind of combat this problem. And you have to taper because you got to wake up the machinery, but then it might not work, and you have to go by. It's quite a tough process. If your adrenal adenoma actually is cancerous, unfortunately, a very bad prognosis. Almost all patients will be dead within 2 years. It's a very aggressive and nasty cancer. Loves to metastasize. Not everybody dies, but the surgeons will try to remove the tumor and treat it that way. They'll also use radiation on the adrenal gland where it occurred, and they'll use radiation therapy, maybe chemotherapy as well, on any places it's metastasized to, and just keep fingers crossed, but it's a horrible prognosis. What about ACTH-dependent causes of Cushing's? Whoops, did that work? Had a cough. I tried to turn it on. It didn't work. I think it's working now. But yeah, what about the treatment for ACTH-dependent Cushing syndrome? And what is that again, dependent? Well, that's almost always, like our opening story, it's almost always a corticotroph tumor of the anterior pituitary. So the treatment for that is, well, there's two treatments. Back in the day, before the invent of fancier surgical technique, you had to just live with the tumor, and you had to take both adrenal glands out, right? Because the ACTH was affecting both adrenal glands. In a good hospital, the mortality rate was still 4% for that, and it's a lifelong cortisol replacement therapy. Specifically, the two that they used are hydrocortisone and one called fludrocortisone. Right? Fludrocortisone. That's a new one. I actually put these slides in this morning. Always trying to improve your educational experience. And yeah, nowadays we don't do that. Pituitary removal, or not the whole pituitary, but microsurgery to remove the tumor is the way to go. If it fails or if the tumor grows back, then we go to taking out both of the adrenal glands. The name of the treatment is for any type of pituitary tumor. Prolactinomas are the most common, but any type of pituitary tumor, the treatment is a transsphenoidal hypophysectomy. Hypophyseal, that's a word for pituitary. Hypophysectomy. And they go right up through your nose. If you stick a pencil through your nose, they stick an endoscope in the same pathway, right through the nasal cavity. Remember, the sphenoidal sinus is right in the back of the nasal cavity, and you can go through the sphenoidal sinus, and you're in the floor of the sella turcica. And then it's all matters. Then it's just, where is the tumor? How accessible is the tumor to that scope? So if the tumor is small, if it's a microadenoma, so microadenomas means the tumor size is under 10 millimeters. The success rate is about 80% on average. It was 70 to 90% is the range. And for success, that means after, it might take a year to kind of re-regulate, but after that time, your hormones are flowing and everything's back to normal. HPA access is back in the groove again. For bigger ones, anything over 10, the success rate is 50%. I'm sure that the patient that we talked to, I guess hers was smaller. Yeah, usually they're bigger than that to cause visual disturbances. But anyway, so only 50% success rate. The trouble is the tumor can regrow. It's hard to get it all. Some of it might have actually grown out through the opening there to the sella turcica. So it can be all sorts of trouble with it. It's always better to get them small. So the risk of our transphenoidal hypophysectomy is hypopituitarism. So it all depends how big the tumor was, because we have a lot of other cells, right? Growth hormones secreting and ones that control the thyroid. There's a lot of cells in there. And you could put that pituitary into shock and those cells turn off and never come back on. And then diabetes insipidus can occur as well if you damage the axons of magnocellular neurons. You could damage those during the surgery. And then you have diabetes insipidus. So there's a lot of risk with this surgery. Not so much mortality, though. It's pretty simple. The mortality rates are very low. But the trouble is you might have to go on tablets and medications to combat having no pituitary after the surgery's over. What about for ectopic ACTH syndrome? We talked about that. Remember, do you remember what the cause of that was? Number one? Yeah, small cell lung carcinoma. So what about the treatment for that? Unfortunately, if you do have the number one cause, small cell lung carcinoma, those are non-operable tumors typically, and so really bad outcome. Most people don't survive more than a couple of years following that. There are other types of tumors. There's a bronchial carcinoma that can occur where you can get at it. It's more localized, and you might be able to take that little ACTH spitting tumor out. There's another one that occurs more rarely, but in the thymus gland. It's called a thymoma, and that can be taken right out as well, and that will stop the ectopic secretion of ACTH. What about the medical treatment for Cushing? Now, we're not going to go crazy into this, but you should know a couple things about it. There is the most common medication they give is, so let's go through it. So me, like egg, like egg, meterapone, is the most common medication that's used. What does that do? That is 11-beta hydroxylase. We didn't talk about this enzyme, but we didn't talk about there is 11-beta hydroxylase deficiency that can occur. And this is the main enzyme that makes cortisol. We'll take a look at it here in a second. But in these patients, or the patients who are overproducing, if they have too much ACTH or whatever, if you give them this inhibitor, it will knock this enzyme out and they can't make cortisol. So before surgery or anything else is tried, you can see how they do with this medication. Remember the pathway here, you're like, oh, no, not this dreaded thing. Yes, this dreaded thing is back. Because we do have to know some of these. I put the 11-beta hydroxylase in here. I don't think I had it in here before, but there it is. All right, and it's over here too, because here's the enzyme that makes it is the CYP11 beta 1. That's the enzyme that makes it. Oh, that's beta 2 over there. That's aldosterone synthase. That's a different one. Sorry. This is CYP1 beta 1, and this spits out and makes. That's the gene that makes the 11 beta hydroxylase, and so we can block that with our medication to stop this chain from going if there's an overproduction of ACTH. Or if we just, no matter the cause, this is the last step in the making of cortisol. So if there's too much cortisol and the cause is a ACTH independent, this will work. Even if it's dependent cause, bottom line is you're making too much cortisol. So you can stop it no matter what type, ACTH dependent or independent, by blocking this step right here. And yeah, that's the deal with that. Here is, I won't hold you, no stars in this slide. I won't hold you to this, but I'll put this in next for you next quarter. Students, I need to talk about 11 beta hydroxylate deficiency because that all the precursor products will back up like crazy, and you get hypernatremia, hypokalemia, all sorts of stuff. So we'll get to that next quarter, though. What about the prognosis for someone who has Cushing syndrome? Do they live happily ever after? Well, they better get it treated. About 50% of them will be dead within 5 years from cardiovascular disease if this doesn't get treated. Remember, the hypercortisolism, it makes the blood vessels, skin, and tissue really thin. It's another one of its sequelae. And so they're prone to have aneurysms, bleeds in the brain. It also, remember, one of the sequelae of this disease is a hypertension. Right, so the hypertension with thin blood vessels is almost like a Marfan's type thing. That increases the chance of bleed in the brain, which can cause a stroke, or a popping of one of the coronary arteries, which can cause ischemia, and that's a heart attack. So even with treatment, interestingly, these patients still seem to be at greater risk for cardiovascular disease, maybe because they've battled it for a long time and some of the damage has already been done. Who knows? Strangely, once the hypercortisolism is corrected, it's really a tough haul for the first few months, maybe even a year. So most of them are used to that cortisol. And when you take it away, they're used to that excess cortisol. Sometimes it makes them feel not too bad. And when you take it away, their hormones just go kind of cuckoo. And they get all sorts of depression disorders and other psychiatric conditions. They get super tired, profound lethargy. Their skin can flake off, and they can get postural hypotension, which isn't corrected very good. So there actually takes 2 to 12 months for things to try to revert to normal with treatment. Without treatment, you're not going to go through this horrible period, but you got a decent chance of dying. All right, so that's finally the end of Cushing syndrome. Let's talk about the natriuretic peptides. So we talked a lot about the little Tasmanian devil, angiotensin II, and this is if that's the yin, this is the yang. Natriuretic peptides do just the opposite that angiotensin II does. And we'll show you that. But let's talk about it. I've learned you don't know very much about it. It's the natriuretic peptides, pronounced natriuret, like bet, na like J, ic, natriuretic peptides. Natrium means sodium in Latin, so its main job is to combat increased levels of sodium, namely hypervolemia and hypertension. Right? Just the opposite. Angiotensin II's job is to lower hypertension, lower pressure. And angiotensin II's job is to boost pressure. And this one puts a cap on it and controls. When the pressure gets too high, this system kicks on, the natriuretic peptide system, or factor system, you could say. And it's designed to combat hypertension. There's 3 of them, actually. There's atrionatriuretic peptide, a.k.a. atrionatriuretic factor. It's another way you can say that. Like the drawing says factor, ANF. So it could be ANP or ANF. Brain natriuretic peptide. And then we have C-type natriuretic peptide is a fairly new one, which we don't know a ton about. Just make a note on this slide. I probably should add the AKAs in there. All right. Let's talk about ANF, atrionatric peptide. Oh, here's the AKA. Atrial natriuretic factor, ANF, ANP. Discovered back in 1984. So sounds like a long, long time ago, but I mean, that was way after my birth date, so maybe not crazy long ago. It is a hormone. Okay, the brain natriuretic, or type C, is not considered a hormone, but this one is. And its job is to promote diuresis and natriuresis. Got it? Promote diuresis. What's that? What's a diuretic do? It flushes water out of your body. It kicks water into the filtrate. And natriuresis, it's the same thing, only with salt. They kick salt out of the body. And by doing that, it can lower the blood pressure. What stimulates its release? Interestingly, no, it's not the hypothalamus. No, it's not the pituitary. And it's not even the brain. It's the heart. The heart specifically, it's the atria of the heart. So the myocardial sites, the atriomyocardial sites, or atriomyocytes that live in the walls of the atria, if they stretch too much, they start spitting out ANP, right? If the ventricles start stretching too much, they spit out BNP. So those guys come right out of the heart. So therefore, the heart is actually an endocrine organ. Is that true? Absolutely. Now, there are some other places the brain actually does secrete a little ANP, and there's other places that secrete it, but 95% of all ANP is secreted in the brain. A little bit can come from the ventricles too, but it's mostly BNP, as we'll learn. What stimulates the release of ANP? Well, think about what stimulates the release of angiotensin II, i.e. renin. What stimulates the release of renin? So it'll be the opposite. So hypervolemia, hypertension, too much pressure in the blood, too much volume of blood, and decreased cardiac output. Let's think about that one. Isn't decreased cardiac output, what's that going to do to your blood pressure? That's going to drop your blood pressure. So how in the world can ANP be stimulated by decreased cardiac output? And this is a big one. It's not actually directly stimulated, it's indirectly stimulated, because decreased cardiac output, what does that do to the juxtaglomerular apparatus? And there you go. Increases renin, right? And increased renin, we know, does what? Increases angiotensin II release. Won't go through the whole pathway because you guys are experts on that whole pathway. So that's going to do it. But we still have, so angiotensin II, what's that going to do to the blood pressure? Got to keep going. Oh, it's going to increase the blood pressure too much. And the increased pressure is going to finally trigger the release of ANP. Oops. Okay, that's the mechanism. And even with this system in place, hypovolemia, decreased cardiac output, these patients still tend to have a little bit of hypertension. It seems the renin, angiotensin, aldosterone system overpowers the natriuretic system. So therefore, people tend to have a little increase, a little hypertension, and too much. We know how bad this stuff is around. But now we have this stuff around, and we have ANP around as well, and they're both not good for the heart. What are some of the things? This is a slide from the past, but now we can bring that back. What are things that can decrease cardiac output? Well, you get yourself a heart attack. You knock out maybe an eighth of your pumping power. You take out a chunk of your myocardium is dead now because of the heart attack. So that's going to decrease blood pressure because you can't pump blood out of the heart. Valvular disease, any one of them, stenotic disease is probably the worst. Aortic stenosis is probably the worst, but mitral stenosis. But regurgitation, all of those conditions don't allow enough blood flow out of the heart. So that can do it. ischemic heart disease. How in the world can that decrease cardiac output? Well, if your heart is a muscle, and if the pipes are clogged that supply that heart with oxygen, and you're always walking upstairs, that heart's always working out. If you're constantly not feeding it enough oxygen, you're going to start damaging the heart and killing off some of the heart. And that's what happens. That chronic decreased perfusion of the myocardium will start killing myocardial cells and leading to scarring. And as the heart scars up and gets thick, it doesn't pump very good. If it doesn't pump very good, there goes your decreased blood pressure, and there turns on the R2A system and that whole 9 yards of stuff again. Okay? Anything that, or any other condition that causes all of these things, they wreck your heart. What's that? If you say, what's one word I can say, or what's a apparent category of all these things? Cardiomyopathy. That's a destruction. The heart muscle is just getting wrecked by different things. Cardiac myopathy leads to the ultimate heart failure, often called congestive heart failure. Why is it called congestive heart failure? Because the heart acts like a beaver dam, and you start getting congestion and pulmonary edema inside your lungs. You get a bad backup. All right? I like that slide, so make sure you know that. What are some other stimulators of the release of ANP and BNP? Well, how about chronic renal failure? Anything that causes hypertension. Chronic renal failure can do the trick. Remember we talked about some of the renal diseases that when the kidney is toward the end phase, it can't kick sodium out, let alone reabsorb sodium. It can't even get sodium out of your blood. It can't clear sodium, and therefore water stays in your blood, too much water, and the balance is upset, and you get hypervolemia, which is the same as hypertension. Nephritic syndrome, same thing, can't clear sodium. How about pulmonary hypertension, COPD? Well, pulmonary hypertension is a beaver dam in the lungs from something, whether it be left heart failure, COPD. That means there's too much pressure in the lungs. That pressure is going to transfer into the right heart. And if you have increased pressure in the right heart, you're going to spit out ANP via the atria and BNP via the ventricles. BNP is brain natriuretic peptide. I haven't got to that yet. I'm not saying V like Victor. I'm saying B like boy. But ventricular stretch causes that to be released. Chronic tachycardias also increase atrial pressure. If you have AFib and your atria are running 500 beats per minute, it's going to be pretty darn high pressure in the atria, enough to spit out ANP too much. You can actually measure the function of the heart by these, as we'll see. Okay, everything I just explained to you about pulmonary hypertension is right there. Right? And the people with pulmonary hypertension will have chronically high levels of angiotensin II, which can also damage the heart, which leads to more cardiac output problems, which stimulates the release of more renin. So you can get this vicious cycle going on here. Well, maybe I should back up. How does pulmonary hypertension turn on angiotensin II? You guys remember that? Well, if we have a beaver dam in the lungs, let's say it's from COPD, then there's not going to be much blood getting out of the lungs and going back to the heart. And so the left ventricle's got a pretty easy job if this is the case. But it's working maybe like 70% of normal, but you have a decreased cardiac output. And that's what turns on the R2A. Decreased cardiac output means decreased blood volume, means decreased pressure, which stimulates the R2A system. Okay, remember angiotensin II's effect on the heart. Yeah, what is the effect on the heart? Remember we talked about the angiotensin II, we know turns on, manipulates the genes of some of the myocardial sites. And some of these genes produce certain growth factors. Kind of a similar sort story about growth factors when we talk about BPH, benign prostatic hyperplasia. But the growth factors also result, some of the genes that's turned on also turn on the pro-inflammatory cytokine gang, and we get a fibroblast heavy inflammation going on within the heart, and that just destroys the space between the myocardial cells, and it gets all scarred up and thick and stiff, and it doesn't work very good. And if it doesn't work very good, and if it can't pump very good, then you're going to have decreased cardiac output, and there we go, the story. Turns on the R2A system, and R2A system secretes too much angiotensin II, and you know the rest of the story. Too much angiotensin II raises the blood pressure, and that stimulates the release of ANP, and there we go. Clinical applications, because the failing heart indirectly stimulates the release of natriuretic factors through mechanisms we just talked about, we can use them as indicators of heart health. So, for example, BNP is released from the ventricles. It's a pretty good marker for left ventricular dysfunction, is to test the blood levels of brain natriuretic peptide, right? Same in a failing heart in general. ANP levels will be elevated as well. It's actually a really bad omen if these natriuretic peptides are elevated. How about some fun facts about ANF? Half-life is only 3 minutes, so it doesn't hang around very long. It has clearance receptors, just like all of them do. We'll look at the receptors in a bit. What time is it? I'm not keeping track of my time. Oh, I think we're good. Exercise actually stimulates a release of it, probably because of the heart's beating harder and blood pressure rises a bit, but it actually feels good after exercise. Exercise does lower your blood pressure, partially based on this mechanism. It constitutively is secreted at low levels, so a little bit of it is released all the time. The ANP and the BNP gene are both found on chromosome 8. Don't think I would ever ask you that. Brain natriuretic peptide, BNP, sometimes it's called BNF as well, but not so much this one. It is produced in the ventricular myocardial cells, as we've said. It's stimulated by increased pressure of the ventricle, just like the atria, and it really mimics the actions of ANP quite closely. It is also, like ANP, considered a true circulating hormone. It was interesting. I took a bunch of slides out, but some of you are going, why in the heck don't they call it VNP for ventricular myocardial or ventricular natriuretic peptide? This was first discovered in the brain, and they thought this was the only place that it was produced, so they kind of messed up and it stuck. They named it brain natriuretic peptide, but they didn't realize that the main producer of it is actually the ventricles. They probably should have looked at the heart first. Since it produces ANP, you'd think that BNP would be produced. ANP and BNP and CNP is produced in the brain at tiny amounts as well, but that's kind of the story behind that. More fun facts, not released in our brains, right? It was discovered in pig brains, and they thought that that's where it came from, but it didn't. Have very similar action and structure to that of ANP. It is a little less responsive than ANP to abrupt changes. Its half-life is a little longer, so it's a little more clunky. It can't respond to real high, like exercise pressure changes. Where ANP is released, BNP doesn't respond as well. Other things that release it besides exercise, sodium loading. People who overload with salt can get releases of this. Position changes can do it. Myocardial infarction causes a greater increase than BNP release compared to ANP, so it can be a sign of myocardial infarction, although the troponin levels are much more accurate. Much more powerful than ANP with regard to natriuresis. There's just not as much of it around. Half-life is 20 minutes, so it's hanging around. Binds less aggressively to the NPR receptors. It's also on gene 8. We said that already. Okay, C-type. natriuretic peptide, also CNP it's called. This one is not expressed in the heart. It's a good question, nice easy question. You would think it would be, but it's not. This one is actually expressed in the brain and in endothelial cells. Therefore, although its function is not super well understood yet, because it's fairly recently discovered, we think it has to do with vasodilation. So it helps vasodilate probably the arterioles and the venules. And then it's got some factor with something to do with long bone growth, the growth of the femurs and humerus. Don't know a lot about that. It's not considered a true hormone, though. It's more like an autocrine and paracrine. So it turns on other things that go out and induce these effects, which we're not going to get into all that because there's just not that much known about it. It does have a similar structure to ANP and BP. Half-life's about 3 minutes. Just not a lot is known about it or its regulation. It does have a natriuretic effect on the kidneys, or does not have any natriuretic effect on the kidneys, like we're going to talk about next time. And here they're all very similar molecules, and there's different enzymes that cleave this kind of precursor prohormone form at different spots. And you can see how you make ANP, BNP, and CNP, or ANF, BNF, CNF, if you want to say that. So where does it bind? It must have receptors, and it does. There are NPR, like NPR radio, NPR receptors, natriuretic peptide receptor A, B, and C. So NPR-A binds both ANP and BNP. These receptors are found in the kidneys, in the adrenal glands, in the vascular smooth muscle of arterioles and venules, and in the heart. So these are the main receptors. There are some NPR-B receptors. These are the ones that confusingly bind CNP. Okay, its distribution overlaps a little bit with NPR receptors, but unlike NPR-A receptors, this one is also found in reproductive tissue and skeletal muscle. In bone in the skeleton. Now the C receptors, these are almost every cell in your body has an NPR-C receptor on it. And this one can bind NPR-A, B, and C. It can bind ANP, BNP, and CNP. And its job is it's a clearance receptor. And so if there's too much BNP around, it can grab the BNP, pull it inside the cell, and destroy it in the Death Star, in the lysosome. So these are clearance receptors. There's some signaling functions, which we're not going to get into too deep. Physiological actions of ANP. Again, the main physiological role is very similar to angiotensin II, but only in reverse. So it decreases blood pressure and volume when it gets too high. It lowers pressure by affecting these systems, the cardiovascular system, kidneys, and adrenal glands. Okay, here's a nice little model, but in general, the big things that I definitely want you to know, this would be a nice question, wouldn't it? There's three. Anytime there's three trivia questions, three fun facts, I can make up a fourth one and make a question out of it. So it decreases ADH, antidiuretic hormone manufacturing, in the magnocellular neurons. It has its receptors on there and shuts down that system. It also decreases the production of aldosterone from zona glomerulosa in the adrenal cortex. And it also decreases renin production it has receptors on juxtaglomerular cells, binds to them and turns them off as well. Those are the main actions. It has some other ones too. It decreases thirst. Everything the opposite of angiotensin II. We might look at this. I'm not sure if we'll look at this more. I got to get to the prostate. So this will probably be the last endocrine lecture. Running out of time. But ANP cardiovascular effects, well, it also decreases sympathetic input, so it blocks the sympathetic ganglionic transmission, so blocks sympathetic input to the heart and kidneys, increases parasympathetic. It's not that it increases it, but if you block sympathetic tone, this automatically increases. That's how that works. Causes vasodilation of the ascending aorta, which will decrease blood pressure. Causes general arterial and venule vasodilation, which definitely is going to decrease blood pressure. If we really want to dig into this, how does it work? I should talk about PKG a tiny bit. More specifically, how does it relax blood vessels? It binds to NPR-A receptors in smooth muscle of arterioles. The binding triggers the release of cyclic GMP, and that activates PKG, protein kinase G. And we won't go any deeper into that mechanism, but protein kinase G ultimately causes a decrease in intracellular calcium concentrations. If you don't have calcium around in the the smooth muscle cell, you're not going to be able to contract that wall and decrease the lumen, so you're going to get vasodilation, right? Remember this. Remember calcium, how it used to bind to troponin, and it would stimulate the tropomyosin. There's that little pink thread that's covering the myosin binding sites. Remember that deal? And then if those are uncovered, we can get a binding of myosin to actin, and we can get a contraction of the smooth muscle. You remember that stuff? Of course you do. Hopefully you do. You got to know that for boards. And let's see. How does it relax? Everything I just said. Oh, here's another factor of it too. PKG also inactivates or activates potassium channels. And so less calcium is around, but more potassium comes pouring into the cytosol of a smooth muscle cell. And then extra potassium hyperpolarizes the cell. So now calcium is not going to even want to come in there. And so it just kind of, without calcium, you can't have a muscle contraction. And if that's not enough, ANP also decreases the release of norepinephrine, aka noradrenaline, from sympathetic nerve endings. Remember we talked about how the sympathetic nerve endings are in the tunica adventitia, and they release norepinephrine, which diffuses lickety-split into the smooth muscle of the tunica media, and that causes a contraction of the smooth muscle. So it shuts down that mechanism. So it has a very important blood pressure lowering effect because of this. Juxtaglomerular cells. Is this where I want to stop? Yeah, let's stop it right there. We'll stop it on the kidney. Okay. Let me check something. Yeah, that's good. That's good enough for today. All right. See you next time.